I request Dr. Anand to honor our chairpersons with a small token of appreciation. I think all of us agree, Dr. Anand has done a wonderful work here, mobilizing faculty for our 2 days thing. In fact, we are going to continue panel discussion there. I think on behalf of CAHO, I request the chairpersons to hand over a memento to Dr. C.V. Anand on behalf of all of us. Thank you, Dr. Anand, for the wonderful work done. Please assemble in the main hall. We are going to have interaction with our Director of NABL and Director of CEO of NABH. You are free to ask any question and get anything clarified directly from the Director of NABL, Mr. Anil Relia. Please come, move to that session.
All printed in the brochure that you all have. I request Anil Relia ji to chair the session.
All of you have a copy of our program. One copy, Anil Relia. Without wasting much of our time, I would like to, on behalf of the laboratory session of CAHOCON, I take this opportunity to welcome on the spot, without giving any prior notice, our director, NABL, Shri Anil Relia ji. He is there in NABL from day one, from the NABL was formed, NCTCF time onwards. We are lucky to have him here, with whom we can really spend some time. It is not possible when we go to NABL office, you'll be so preoccupied with so many things. And you know our other colleagues, Dr. Anand and Suresh and Sitalakshmi, Usha, and then Jairam. I am Venkatesh. We shall start. You are all ready, prepared with the topics which is in front of you, and Dr. Anand will give a brief note on this topic.
Good afternoon, everybody. In the morning I saw the hall was full. Now, either some people have gone to the other. Okay. So maybe when we start, it will pick up. The people will join us. Okay. Now, we have a very interesting session now. Let's debate. It's almost an open session, where we have number of topics, and all these topics are very important and interesting, because when we were formulating our technical document, NABL 112, all these topics came into discussion. We had formed a technical committee where we got experts from our own fraternity, those assessors who had done about 100 assessments. We formed a technical committee and they had deliberated on that. The 112 is a ready document. There is some lacuna. We are awaiting MCI's clearance, and that soon will be probably published. We'll start with the topic number 1, managing a successful POCT program, by Dr. Venkatesh Rupil.
This morning I have already highlighted about the future of POCT. Laboratories are getting miniaturized now. Huge instruments are becoming smaller and smaller, thanks to scientists and engineers who have contributed a lot. And this point of care testing is a bedside test. Today, about 90% of blood glucose is estimated at the residences using glucometer all across the world. And earlier, I remember my grandfather used to test his urine using Benedict's reagent at home. It was always kept in the toilet. It was not allowed inside the house. He had a test tube, spirit lamp. He used to transfer to particular mark, boil, add some urine, and he was knowing whether there is a sugar or not. Point of care testing started during my grandfather's time. Now what will happen to my grandson's time, I tell you. What was there in the urinals, urine will go to laboratory, as on today. Future, laboratory will go to urinals. I will tell you what happened to me, my personal experience in Japan a couple of years ago. I was in Kyoto for a conference. I wanted to go to Hiroshima, Nagasaki. I had told to some of you. I came to Tokyo railway station to catch that super fast train. I reached there at morning 7 o'clock, though the train was at 9 o'clock. Nobody was there. Like in India, we go 2 hours early, 1 hour early, we are used to that. Nobody was there except me. There were some shops partially open. What to do? I could see only myself in the mirror, nothing else. And one of those shops or two of those shops opened. I went and saw. Everything was written in Japanese. I could not understand. Then when I asked for that green colored fluid, he said tea. I drank tea. In another place, I drank water. How to spend time? Then I drank some orange juice, and bladder started blowing. It got filled. At this age, to hold the urine in the bladder was also difficult. Then I wanted to empty my bladder, for which I was looking for a urinal. At one corner, I saw one opening. There were 2 photographs on either side, 2 pictures. Any picture on either side of the entrance definitely is urinal all over the world. No doubt about that. I went closer to that. Both the pictures, left hand and right hand, were looking alike because Japanese male, female looks alike. And then I was hesitating to enter because they had fixed some cameras also to monitor, surveillance camera. Came back. Again urge to go. Again I went, came back. More and more you think of urinals, more and more micturating pressure going to the bladder, you have to empty the bladder. Then it was uncontrollable. So one gentleman saw me by the time few people came, and he saw my status. He realized, he called me. He could not speak to me in the language in which I could have understood. He lifted his little finger like a school child. In schools we always lift the little finger. I said yes. Then he said go. I went inside. More confusion. Inside there were 2 more entrances, one on left, one on right. When I entered, all the lights were on without anybody. All sensors were there. High tech. Urinals, I should tell you. Then the lights were on. I heard one by one in different language. And when it came in English, he said, left side. There were no pictures on left side or right side entrance. I did not know whether to go to the left or right. Then it said left side is for free. Right side is for paid. That means Dharma Darshan. In temples, when you pay money, you can have quick darshan. There also. Then what is that paid? Then I came to there was a counter. It was there written $10 to empty bladder on the right side. I thought there will be sofa inside, some more shops for green, yellow, orange drinks and water. Maybe some more eats also. Then I searched, I had $10. I inserted that $10. I got a metro coin, that Delhi metro coin, plastic coin. I said insert it in one pouch. I inserted it. And I got a headphone. And also another coin. Said, I got instructions to go in the right side. I could have taken the left door free. I could have finished my job by this time. I went into the right. After going there, said, wait, you have to go to Toto number 7. I had to count from left to right or right to left, I did not know, because the numbers were all in Japanese. And it was confusion, a lot of confusion. So luckily that 7 was in the middle, odd number. I went there. He said, wait. Alright, bladder is full, urinals in front of you. You have controlled for last 1 hour. Wait means what? That weight, that particular weight meaning I realized that moment. Inserted, then it said red light will come, yellow light will come, orange or green light will come. Insert the coin, wait. When it says go ahead, pass urine. I tell you, what a procedure. Passed urine. First time in my life, I tell you, I had such a great pleasure of emptying the bladder. I tell nobody was there for me to explain. I'm telling it to you. After that, wait. After emptying bladder, why I should wait? Take the printout. Printout came of 23 urine parameters signed by a pathologist like him, biochemist like him, and not only that, accredited by Japanese accreditation level. Stamp is also there. I tell you, fantastic. $10 is worth it. Then I came out with that. But you have to wait till the bladder is full to go and recheck whether the first report is correct or not. Repeat test. I came out. I was so happy. I have retained that report even today. In India, urine goes to laboratory. In Japan, laboratory has gone to urinals. Calibrated, accredited. Look at the point of care. Not only that, if this is high, whom to contact, phone numbers are also given. When I came out, now I will extend it. What will happen in future? Point of care will be marrying what is called point of treatment. Outside, a huge fellow looked like a militant with a belt with lot of bullets like thing. I was curious. I went round and round. Then he spoke in English. He said, "You know what it is?" I said, "I would like to know. I don't know." Then he said, "I am diabetic. This is my insulin pump. Last 3 months ago, I had my kidney transplant. This is my cyclosporin or some other drug. I have a cannula inserted. It measures the circulating insulin, a circulating drug. Whenever its level goes down, I don't have to worry." He was carrying laboratory and pharmacy on his belt. This is called the future. Future, why I'm telling you, we pathologists, biochemists and microbiologists will depend on technical support and clinical engineers, not biomedical engineers. They are now called clinical engineers. Clinical engineers will become our guides. Today, when we never learned statistics, today we are dependent on statistics. We never learned about the biophysics, we now depend upon biophysics. We never learned any engineering, we depend upon clinical engineers. Now, the future has challenges and opportunities as far as point of care testing. Our ISO 15189 2012 edition has highlighted a number of places, as Suresh has already highlighted today. The point of care testing is the future. What is next? Biochip inserted inside under the skin will be monitoring all the parameters, sending the signal outside through body electricity, and it will be captured on some clinician's table, and he will be sending message even before you go to pharmacy. Pharmacists would have supplied drugs to you. This is the future.
Oh, that's very interesting, Dr. Venkatesh. See, whenever you are listening to Dr. Venkatesh, he will add up a very good story so that, like anecdote, yeah, so that the effect is very much there. Well, the future will also be that the drugs are also inserted in the body, and it will draw that drug which is required. It may happen that certain drugs are inserted in your body. Sustained release is there. Only when programming is there, they will see what drug is required. Otherwise, it will retain. So this is probably will come. Okay, we will now go to our next talk by Dr. Sita Lakshmi Subramaniam. State-of-the-art approach to diagnostic hematopathology.
So good afternoon to all. So just to initiate the discussion, I'm sure there are multiple views and multiple contributions to this aspect. It's very broad. So the diagnostic approach to a state-of-art hematopathology laboratory. So if I can just think back, the hematology practice has evolved very drastically over the last 2 decades, and it's transformed completely, I would say. Initially, probably it was just light microscopy, and all our diagnosis was based on simple microscopic examination in the background of clinical knowledge. But today it's a conglomerate. Several subspecialties contribute to hematology diagnosis, and I'm sure the clinical hematologist would agree that one cannot practice hematology without good support of immunophenotyping, immunohematology, molecular genetics, cytogenetics, and so on. So it's a blend of all this in the appropriate clinical setting. Of course, we cannot forget the conventional microscopy, which continues to be the mainstay. So it has several aspects put in together to make a good hematology practice, because for the diagnosis and for planning treatment, one needs all these aspects put in together to take it further. I'm sure the audiences will have several things to contribute besides the panelists. Can I invite discussion from the others in the group, or questions, anything? I've just, to initiate the discussion, I've put some thoughts that came to my mind, but I'm sure all of you can contribute. Anybody would like to add on or say something different? Welcome.
Now, since the current focus is on evidence-based medicine and on personalized medicine, I think the state-of-the-art approach to advanced hematology would be multidisciplinary, multi-pronged, where you need to integrate a number of data sources, number of information points, and ensure that the final report which goes out incorporates information from all these segments. So I think that becomes one very important aspect of the state-of-the-art approach to whether it's hematology or any other discipline. So data management becomes important, integration of data becomes a very important factor.
Questions, Amila? Questions, Amila?
Get ready for interaction. After all of us panel presents, then we can have an interaction. Right?
Okay. So we decided we'll have the, okay. Number 3 presentation, Dr. Muralidharan is not here. If he comes, we will have it later. Next is pre-examination documentation by Dr. C.V. Anand.
I hope all of you know the meaning of pre-examination documentation. What happens in the examination area is, the actual testing process takes place. Before the actual testing, earlier we were using the terms pre-analytical, analytical and post-analytical. Now it is changed to pre-examination, examination and post-examination. That's because not everything is analysis. There are some things which are only examination. We don't analyze everything. That's the reason why the standard changed from pre-analytical, analytical and post-analytical to pre-examination, post-examination and post-examination. Now this pre-examination documentation is very important. That's where, in morning you have seen, most of the errors take place there. Most of the errors, 65% of the errors of the laboratory takes place in the pre-examination area. Hence we should have a manual called as a primary sample collection manual. We should include all the procedures for collection activities. The collection of blood samples, collection of urine samples, collection of semen, collection of stool samples, all these are collected, and for that instructions have to be given clear. That consists of pre-examination documentation. Now everything has to be documented. It need not be documented on paper. It can be even documented in a computer. What time the patient arrives, what time if the tourniquet is drawn, what time is the blood sample drawn, what time is it centrifuged, what time it is transferred to the laboratory. So all these pre-examination documentation plays a very important role, because ultimately they may play a major role in the results.